presentation, which is going to be. Is everyone seeing my share? Hello?
Not yet. Not
Okay.
yet.
What about now?
Nothing on my end.
Wait.
Maybe try to reshare. Like,
Can you try to reshare?
I think you've not made him to be the co-host, so he's not able to share.
Oh, okay. Let me just
Right. Make me the host.
Let me just make you co-host.
Share my screen.
Okay, try now.
Are you seeing
perfect.
it? Perfect.
It
All right. I guess it's in full. It's in full screen.
It shows that
Hello?
you're sharing. Okay, perfect. Yes.
All right. Today, our main goal is to have, let me see, a learning experience together. That's why we came up with this presentation. And under this case study, it was done at Mukono Orthopedic and Trauma Center. And the technique was got from Acure, the leading radiology school in Uganda. And we came up with a case of the role of a pelvic X-ray in an ankylosed hip. Under our stats, let me say, an ankylosed hip. It's simply meaning that it's a condition where the hip joint becomes stiff, immobile due to fusion of some of the bones within the joint, as we are going to see in our anatomy. So those ankylosis, an ankylosed hip, it may result, the risk factors to it may result from trauma, infections, inflammation, osteoarthritis, and genetic factors prior to surgeries, and many other things which we can't even complete in this short period of time. Ankylosed hip refers to restrictions on the movements of hip flexions, extensions, rotations less than 10 degrees, and might be achieved spontaneously all after surgery. The risk factors, as I had said, we have a risk factor of trauma, for example, fractures or dislocations. Fractures or dislocations, they might contribute to this pathology in such a way that, let me say, okay, they can increase the risk of developing, let me say, an ankylosed hip. When we have infection, in some cases of an infection of the hip can lead to inflammation and infusion of bones, resulting into an ankylosis, as I've said. Then we have genetic factors. For example, in some families, or some, people with some genes in your family lineage, some individuals might have a genetic predisposition developing, excuse me, mute. They can be having a genetic predisposition to developing an ankylosed hip. Then prior to surgery, in some cases, after surgery, previous surgeries, let me say, involving the hip joint can also increase to those risk factors, especially if complications or infections occur during and after the procedure. Okay. So, and we go dive into pelvic gross anatomy. The pelvis consists of the hip bones such as the sacrum, the coccyx. Each hip bone is formed by the fusion of three bones, the ilium, the ischium, and the pubic, as shown in this image. So we have the iliac crest, which are bilateral. We have the ilium, which are also bilateral. We have the sacroiliac joints between the sacrum and the iliac. Sacro and the iliac, sacroiliac joint. The sacroala, the sigmoid colon, which is not even involved on our bony component, the acetabulum, the fovea, the femoral head, the femoral neck, the greater trochanter, the lesser trochanter, the obturator foramen, the ischiotubrousity, the superior pubic ramus, and the inferior pubic ramus. They are bilateral to each other, but in such a way, our pelvic anatomy, briefly, the pelvis provides, let me say, support to abdominal organs, such as intestines. That's why you are able to see the sigmoid colon, the coccyx, the rectum, that cause for its important role to us. The bladder, and it serves as an attachment site for, let me say, the muscles involving the movement and stability, including the gluteal muscles, hip flexors, and the pelvic floor muscles around here. So we go on to the case which brought us here. It was requested by a doctor from the orthopedic department. The examination involved of the examination on his indication, he requested for a pelvic x-ray, anteroposterior view, including the hip joints. The patient history. This patient was a female. She had pain in both hips for a long time. Let me say, was it a month? Yeah, it was a month. More than a month. There were months. Failure to use both lower limbs normally. She also had a limited range of motion in both hips. And definitely she was 15 years old. Clinical presentation of this young girl. She had an abnormal gait. What do we understand by an abnormal gait? So this gait, it's usually in the lower limb, and it refers to an atypical or irregular walking pattern. So in this case, this girl, she came when she's having an irregular walking pattern, which might have been caused by various factors, let me say, including musculoskeletal conditions, as we are seeing, neurological disorders, or injuries. Some common examples of abnormal gaits include limping, dragging the leg, shuffling, or wide-based unsteady gait. These abnormalities can result in difficulty with balance, coordination, and overall mobility. So in this case, the doctor decided to request for the pelvic x-ray, including the femoral joint. The patient also had a painful gait. I've already explained what a gait is. The patient, since it was more pronounced on the left, the patient also had a left lower limb shorter than the right lower limb, as we are going to see on our radiograph. So, as a person in the radiology department, I have to sensitize you on how we prepare the patient. So I created a rapport with this patient. She was 15 years old. This rapport, it was meant to make her disclose some of the history, some of the biodata, the sex, the age, and also provide me with the history as well. So I got the name, the age, sex, and the patient ID after seeing the request form. I provided the patient with a gown so as to ensure, let me say, privacy. Technical factors that were used. I used the 14x17 image receptor. This image receptor is the largest in the X-ray department, and it's either gridded or the grid is embedded in the bucky. So this procedure is gridded. The FFD was 100 centimeters, also to image distance. Most of departments here in the country, since it's a village facility, some facilities which are not sensitized, they may not shield the radiosensitive organs of the patients so as to concentrate on the desired anatomy. So they just expose each and everything without shielding the radiosensitive organs, such as the thyroids. I used the horizontal bucky, the X-ray tube. The KVP was between 70 to 80 for sufficient penetration. MAS, milliamperes, contrast as 20 to 30, and the shortest exposure time as possible. Orientation was landscape. Technique. Under our technique, it was an epi projection. The central ray was centered at the midpoint of the anterior iliac spine, as I've showed it to you in the anatomy. You have to palpate after getting consent from this patient, and the pubic symphysis. So 2 inches above the pubic symphysis, that's where we're going to find the pubic symphysis. That's where we're going to find a correlation of the anterior iliac spine, the CIS. Then we collimate to the lateral skin margins. Don't use a wide beam. So as a wide beam may lead to scatter radiations. You as a radiographer, you're going to be damaging yourself as well, and thinking that you're only damaging the patient. That's our lateral principle. It beats on that very much. It targets on that. We use we can achieve our image using low factors and sufficient ones to this. We collimate to the lateral skin margins, superior to the above the iliac crest, inferior to the proximal third of the femur. Internally rotate, open up the obturator foramen. This was so interesting at this time. This patient could not even internally rotate. So we could not open up the obturator foramen and the femoral heads were not able to align to the IR. So this is because there was fusion. So this patient was not even internally rotating to the midline. So she failed. She failed to internally rotate. That's why it was interesting to make it a case. Before these images are passed to the radiologist, we have to evaluate them. The iliac wings have an equal concavity. Those are the birds of the pelvis, the wings of the pelvis. They should have a symmetrical equal concavity. The entire anatomy should be demonstrated without cutting off an anatomy to ensure proper collimation. In case the anatomy is cut off, that means you'd never collimated very well. You have to be very careful not to collimate out of the anatomy. Either you might reduce the collimation or increase the collimation. So when you increase the collimation, you are going to be having an image with scatter. Even you, the radiographer, you'll be damaging yourself. That will be, you would have disobeyed the Alara principle, which was stated by our people who were passing the Atomic Energy Council, Uganda Atomic Energy Council. So the sacrococcygeal joints 1 to 3 centimeters superior to the upper surface of the pubic symphysis should be all visualized. So this is our radiograph. And this radiograph is showing the fusion, ankylosis, clearly shown here. And that femoral insertion, where it inserts into the pelvis, you see as if there is an attachment. There is no movement, which might either be callus formation or what, but it's stiff. That's what is causing the patient not to be able to either have movements easily or find difficulty in the motion. You see, there was a bit of rotation. Since this patient was not able to rotate, to internally rotate the femur inward so as to open up arbitrator foramen. But our wings, pelvic wings, or pelvic girdle of the pelvic girdle appear to be symmetrical. There was that difficult. We tried to position the patient very well so as to come up with a diagnostic image. The report writing. Under report writing, we had the general findings. And the general findings for that person, we had lower limb shorter than the lower limb shorter than the right lower limb. And differential diagnosis also apply. And treatment, they manage this patient by doing a total hip replacement for both hips, which were successful. Other imaging modalities, we can do an MRI, a T1 turbospin echo, which is a coronal, a T1 turbospin echo coronal 4 millimeters, a T2 star axial 3 millimeters. Okay, in summary, we can go for as well an MRIs as another modality. Because when I start talking about turbospin echoes, those also need a full presentation. Then we can as well do a CT scan following the pelvic protocol. Remember, this is a traumatic patient. We might not give contrast. The references were Radiopedia, Miller's Review of Orthopedics, Campbell's Core Orthopedic Procedures. Then Professor Kaja, an orthopedic surgeon. Thank you all for listening. We can get remarks from Professor Isaac Kaja in case he is around, so that he can give us some knowledge on how we can manage such patients. Thank you very much. The floor goes back to you, the audience listening. Questions are welcome. We share the ideas.
Okay, thank you so much.
Long live Ecury and
Yes.
Mukono Orthopedic and Trauma Center. Thank you very much, Towera.
Okay, thank you so much, Ronald. But maybe before we go into the questions and answers, if Professor Kaja is in, maybe he can give us also his thoughts on this just before we call in for questions and answers. Professor, are you still here? Okay, maybe Prof has logged out. If Professor Kaja is not here, then we can come to the session for questions and contributions from the audience. So you just please raise your hand. We'll give you an opportunity to speak.
Towi, Professor Kaja is there. He can tell us how he managed the situation in a short period of time. Though he's using Karen's iPhone, that's his